Assalamu alaikum. It is a great honor for me to have been invited by this distinguished Egyptian Society of Endocrinology. There's a slight modification of there's two talks, but just to, I think it makes more sense. I'm going to be talking about the long-term outcomes and complications of bariatric surgery, which was one talk. But then I'm going to make a case of the sleeve gastrectomy. So it's all connected. Then Dr. Abdel Baki is going to talk after me about the mini bypass. I think that makes a little more sense, and maybe you could get more out of this session. We heard a lot about the statistics, about the severe problem of obesity. It's one of the critical, problems, mainly in the United States, Alaska. It's in the developed countries. Even, Saudi Arabia has been affected quite a bit. I don't have specific data about Egypt, but as we heard yesterday from Dr. Al-Sayed, that Egypt is among the 10 top countries with the highest incidence of diabetes. And, obesity and diabetes goes hand in hand. So those are actually the two most common metabolic problems. So the endocrinologists and the surgeons, we have a lot of work to do. And the problem is on the rise. Over the last decade, we have seen, more than doubling of the different BMIs, the BMI that skipped too much. The BMI of 30, 40, 50s, they have more than doubled over the last several years. And, with that increase in obesity and the BMI, we see a lot of more, mortality. This is associated, as you know, with not only diabetes, but the cardiovascular risk factors, sleep apnea, kidney problems, liver problems, you name it. Every organ failure, every organ system is going to be affected one way or another. So just to give you a brief history of bariatric surgery, because we know there's a need, to do surgery, but usually we don't jump right away to do surgery. Actually, the patients, they meet strict criteria to qualify for bariatric surgery, and they have to try, diet and exercise. They have to be committed before they qualify. And we want to do the safest surgery. Initially, the surgery we know it works. The bariatric surgery has been around for many years, since the early 1950s, when the surgeons started doing the intestinal bypass, which had a lot of complications, and it was abandoned. The gastric bypass had been around for a longer time, but it was not popular because it also had a lot of complications, because it was done in the open fashion, a lot of surgical problems. The vertical banded gastroplasty, it was popular in the 80s, and there was also a lot of complications with it. There was erosion of the band, and it was also abandoned. The weight loss surgery actually became popular in the early 90s with the introduction of laparoscopy. When the surgeons, we start doing the laparoscopic cholecystectomy, gallbladder. Then at the same time, actually the gastric bypass, we start doing the gastric bypass, using the minimal invasive techniques, small incisions, and there was a tremendous change in the field of surgery, with the less pain to the patient, less complications, and with the excellent outcomes. So that's when, in the early 90s, when it became popular. Then we have the gastric band. The gastric band actually was popular in Europe, and then in the United States, several hundred thousands of bands, were placed. But, it did not last too long, because it did not work very well, and it was a very challenging tool to make it to work, because it has to be adjusted, and, there was compliance issues. So now in this decade, we see a demise of the band, if you want to call it. We still do few bands, but actually it's dying away. and we see a rise in the sleeve gastrectomy because we think it's a very safe surgery, and we don't create any new problem with the sleeve. We don't burn bridges, and it works as well as the gastric bypass. So that's the trend that we see now. So these are the most common bariatric procedures that we are doing. We have the gastric bypass, obviously. We have the sleeve, the second one. See this point, I have to work this point. I use the point. So we have the gastric bypass, the sleeve, the gastric band, and the duodenal switch. So what do we know about weight loss surgery? Well, we know it works. We know it's the most effective way to deal with morbid obesity and the comorbidities. This is a proven fact. There's a lot of data out there. And we know it's safe. Now that the mortality used to be 0.1%, now is down to 0.3 to 0.05%. This is very safe in the surgical field, almost as safe as doing hip replacement surgery or even gallbladder surgery. And we know it improves the quality of life and improves the comorbidities. At least 2/3 of the weight-related comorbidities will resolve, including the diabetes type 2, at least 70% will resolve. 90% of the fatty liver disease that we heard about yesterday, it will resolve. Actually, there's a projection in the next 5 years that the fatty liver disease is going to replace hepatitis C as a cause of liver cirrhosis and a need for transplant. So this is a huge problem. Also, the obstructive sleep apnea will improve, and the dyslipidemias and the cardiovascular risk factors. 86% of the metabolic syndrome problems will resolve after surgery. And also we know that it does prolong life. We have compared patient, morbid obese patient that have surgery and patient that did not have surgery. There's at least 1/3 decrease in the mortality in the following 10 years after doing weight loss surgery. Okay, so which operation then we're going to choose? Obviously, what's the ideal operation? If there's any ideal operation, probably the ideal thing is not to do any operation, but we know that sometimes there's no choice for those morbidly obese patients with all those problems. But we want to choose the surgery that is safe, less invasive. We want to choose a surgery that has less alteration to the GI anatomy and function. We want to choose surgery with less morbidity and mortality, and with fewer long-term nutritional and metabolic side effects. After saying all this, we have to make sure it works. So that's the main thing. Those characteristics, I find them all in the sleeve, and we will show you why. Just a brief, quick overview about the gastric bypass, because I see some new faces back there, just to refresh your mind. The bypass is done all laparoscopically. We divide the stomach in two portions, so we leave this is the gastric pouch, it's about 30 to 60 mLs. The rest of the stomach stays in place. Then we're going to divide the intestine further down here. Then this is the rulen that we're going to create and measure. It's 150 centimeters. It's attached to the pouch. And then the biliopancreatic secretions, join the food, and the mixing and the digestion starts from here down. So in this way, it does restrictions. The patient eats less calories. And, since by the time the food gets down here, it has already traveled 5 feet of small intestine. So that's less absorption. They can absorb less. And obviously, they're going to have malabsorption. They're going to absorb like the vitamins that we absorb in a normal way here, especially iron, calcium, folic acid, B12. So those patients need the long-term nutritional supplements, and it could be a serious problem if not taken. this is those are the advantages of the bypass. Has a very fast, weight loss. Usually, the average weight loss is 65%. And 6 months after surgery, they lose at least half of this of the average. It has a very long track record. It used to be the gold standard, but I think now they are changing, and I think the sleeve is kind of beaten up, this operation now. Again, it has a restriction, it has malnutrition, but it has higher incidence of complications still. It has higher incidence of complications when we compare it to safer ones, like the sleep. It has this is a very powerful tool for the control and cure of the diabetes. And the main mechanism doesn't depend as much from the weight loss, because immediately after surgery we see tremendous improvement of the glucose metabolism. And this is the theory, you heard about the hind gut theory, because the food is delivered to the hind gut area. Then we see an exaggerated postprandial insulin and GLP response. So those are the more advantages of the gastric bypass. Especially, it has beside the diabetes, it's excellent for the metabolic syndrome. Like we mentioned, 86% of the metabolic syndrome will resolve. It has a very strong and powerful effect on the dyslipidemias, with the superior effect on HDL, LDL, cholesterol, with normalization of the blood pressure. All this data comes from the Swedish obesity subject study that followed, bariatric patients for up to 30 years. And they saw the long-term efficacy lasting at least 15 years with a documented survival benefit. And as we mentioned, it has this unique benefit of glucose metabolism due to the insulin and GLP response. However, everything comes with a price. So this is, we have to pay a price. We create some problems to the patient. It's an excellent surgery, but the patient has to worry about all those things. The overall complication rate, it's about 6 to 15%. And in the first 30 days, there's always with any surgery, there's a small chance of mortality, but it's very low, as we see, 0.05 to 0.3%. The morbidity is about 2 to 3%. But the patient has to worry about, several, after they heal and everything is fine. If you see one patient with a dead bowel from internal hernia, you're not gonna ever forget that, and you're gonna think it twice when you do a gastric bypass on those patients. We don't see this problem of internal hernias too much, because now with the laparoscopy, we close all the defects. Usually internal hernias is the bowel gets trapped like behind the small bowel anastomosis or through the defects that we create surgically. But now we close them all and we don't see that much of a problem. But it is a patient that had the old bypass. Every patient that comes with abdominal pain, significant vomiting, we have to consider them as having a bowel obstruction with internal hernia until proven otherwise. Sometimes the CAT scan shows it. If it doesn't show it, we have to put a laparoscope and make sure the bowel is not compromised. The anastomotic strictures, usually about 5% of the patients after gastric bypass, they need the gastrojejunostomy to be dilated. And usually that happens during the healing process between 4 and 6 weeks. The marginal ulcers are a long-term, risk. We give PPIs for at least a year, but some patients, they go back and they start smoking and they use aspirin or other non-steroidal agents, alcohol. They are at very risk of those ulcers, and they usually develop right at the pouch. They come with a gastric upper GI bleeding. Some of them have perforation of the ulcers and need surgery. The dumping syndrome syndrome, the early dumping syndrome, could be good or bad. Dumping syndrome usually happens, if it happens, because it only happens in 40% of the patients, and it happens with the intake of simple carbohydrates. The patient they start sweating, they feel dizzy, the heart starts, pounding fast. But usually if it happens, that's controllable with diet. They have to understand that they are eating the wrong nutrients. However, it could work against them because a lot of patients, they don't feel that dumping syndrome, no matter if they eat ice cream or shakes or whatever, and they could regain some of that weight because they don't feel any restrictions and they don't feel any dumping syndrome. You are also probably familiar with this, hypoglycemia after the gastric bypass, postprandial hyperinsulinemic. The incidence of this actually is not known, but I think it's more than what we thought. It could be about 10%, and it could be serious, severe hypoglycemia. Usually this happens like between 1 and 3 hours after the meals. It could be controlled if it happens with diet modifications. The patients have to take small meals, and eat more often. And in severe cases, the bypass has to be reversed. So after going through all this, then we did an excellent surgery, excellent results, good weight loss, but 1 out of 5 patients will regain significant amount of weight after going through all this. So that's another problem. Why they regain weight? The few patients would have some technical problems, like the pouch would dilate too much, or there's 1% chance that the pouch would reconnect to the remnant of the stomach, gastric fistula, or they could dilate the gastrojejunectomy. That's very hard to treat, except if the pouch is too large, we could trim it again. But the majority of those patients, they have normal anatomy. We look inside the pouch, it's still very small stomach. The gastrojejunectomy could be dilated more, and they stop feeling that restriction over time. And they eat more, and they regain a lot of weight. And we don't know what to do with those patients. There's few devices we tried. There's a suturing device that we could narrow the gastrojejunectomy, but still after a while it's going to dilate again. So those patients with weight regain, or patients that did not lose enough weight, then they benefit from medical treatment. And there's a lot of drugs in the market, the GLP-1 receptor analogs and a lot of other, medication that you know about that they need. They don't need more surgery, they need medication. Those patients that have the gastric bypass, it's very difficult to modify or reverse. And we also have to understand that every patient will lose different amount of weight. First, we have the normal distribution, like this is the distribution of weight loss after gastric bypass. 50% of the patients will be in the average weight loss, but we're going to have 25% below average and other 25% above average. So this is a normal distribution. It could be also related to their genes. Patients will lose weight differently, and there are some studies also. There's a correlation between genetic relatedness and the outcome of the gastric bypass. You see, this is the identical twins. There's no difference in how much weight they lose after surgery. However, the ordinary people, there's a tremendous difference of how much weight they lose. People that live together also, they're going to lose a different amount of weight. And first-degree relatives, they're going to be somewhere in between. There's other factors that also affect the weight loss. We know the super obese patients with BMI more than 50, they're going to lose more than the smaller ones. There's a recent study from Portugal, actually, that showed patients with higher levels of T3 before surgery, and if they have normal thyroid function, those patients, we could predict that they're going to lose more weight than the other patients that don't have elevated T3. Most of the problems are social and psychological. It's behavior modification, social diet. We heard about the nice talk from Dr. Al-Suhaili, where the problem comes from, and it's going to come back no matter what we do if the patient is not really committed. Of course, the technical factors that you mentioned and the type of surgery, there's different lengths of Roux-en-Y, but the standard one is the one we use, but still there's some variation. There's also changes in the diabetes remission, and this is also from the Swedish obesity subject study. We know that initially the diabetes remission is about 70%, at least 70% at 3 years, and that goes down to 58 at 10 years, and all the way down to 40% at 15. So why this change in the diabetic remission? One of the main factors is the magnitude of weight loss. If they lose a lot of weight, they're going to keep that diabetes in control for a longer time. We know that young patients, they tend to do better also. The length, how long they've been with the diabetes is very critical. We want to make sure the patients still have reserve of the beta cell function, as we heard in the previous talk. And more, usually we want to operate on them earlier, ideally before 5 years, but the data shows that less than 8 years duration, they have better outcome. And we heard about the other sensitivity and the beta cell function that you all know about. That's a very important factor. However, it doesn't matter if the diabetic remission it's affected. There's a legacy effect that we call that is going to last. The benefits will last even longer. Even if the diabetes is going to come back a little bit, but they still going to have benefit of the micro and macrovascular disease that is associated with diabetes. The band, just very, very quickly, we thought it was going to be a great tool, but it's not. It is simple to place. Usually it's placed just below the EG junction, and it's reversible. It's a purely restricted procedure, and technically simple, but it doesn't work. Again, I think the challenge with the band, I've seen patients that they have done great with the band. They have several patients, actually they have done better than gastric bypass patients, but they are few. And the problem they run with is the adjustments of the band. A lot of the patients, they want the band to be too tight, they want to make it tighter and tighter, and it doesn't work because the food has to go through, and it doesn't. Then they start eating, their own stuff, the soft, ice cream and shakes and all that. So, and they end up with a, very dilated esophagus, and they start having acid reflux, and it doesn't work. Actually, they start gaining those patients. Also, there's a risk of slippage. You see the stomach slips. This is the band here. The stomach slips above the band, and then you have gastric obstruction. This could be chronic or acute, and it could be fixed. But a lot of patients, we have to take it out. But could be a serious problem if it's not relieved on time. And that's 2% chance of slippage and also band erosion. Okay, so this is the new kid in the block. It's been around for 7-9 years. This is the sleeve gastrectomy, laparoscopic sleeve gastrectomy, and it was first done by his and Merciu in 1998. And the way those surgeons started doing the sleeve, they looked at the super obese patients, and they thought it's very risky to do to them the bypass or the duodenal switch. So they did this first stage, very simple. They just divide the stomach and remove all the fundus and the rest of it. And after they followed up those patients, and they found out they lose as much weight almost as the gastric bypass. So there's no need to go further and do the malabsorption. And that's when the sleeve became very popular as a standalone surgery. It's simple, but there's few things. Not every sleeve is the same. We have to take measurements. We have to leave the pilorus intact and the antrum. So we measure like 4 to 5 centimeters pre-pyloric, and then start start dividing, we have to mobilize all the stomach and the fundus, very critical, not to leave any fundus behind. And then behind the stomach, usually there could be adhesion, so we have to release that from the pancreas. So after everything is set, then we place a sizer to see how much stomach we're going to leave before we start dividing with the stapling device. Usually that sleeve is about 120 to 130 mLs, but it's all connected naturally to the rest of the intestine. There's no connections. There's no chance of ulcers, no chance of dumping. The pylorus is still intact, the antral pump. There's minimal malnutrition. We give the patient like calcium and iron because they're going to be eating less and they have less stomach, and the acid is needed for those things to be absorbed. So we tell them to take one multivitamin with calcium and iron, and that's it. But we don't create any serious problem to them. So this is the trend worldwide. And there's like 500,000 cases of bariatric surgeries done, every year. We see a steep rise of the sleeve gastrectomy, and the bypass, plateaued here, and actually it's going down. The band, you see, it's the rise and the fall of the band. In the United States, we do probably half of those operations in the United States, at least 200,000 cases a year. Most of them, 50% of them are sleeves. The 23% gastric bypass. We still do some bands, about 5%. The duodenal switch is still around, about less than 1%. And now we're doing a lot of revisions, especially removing the bands and converting those patients either to a sleeve or to a bypass. There's other endoluminal procedures. The balloon, it's been done in the United States. There's over 1,000 cases now performed. And there's some electrical stimulation devices, electrodes, that we place on the vagal. One of them, if we have time, I could show you a picture of the V-block. So what's the mechanisms of how the sleeve gastrectomy works for the weight loss and the type 2 diabetes? As with the gastric bypass, the restriction is the main thing. They're gonna eat less calories, they have less capacity. One of the major mechanisms is the decrease in the hunger hormone, the ghrelin. You all heard about the ghrelin, which comes 70 to 80% of ghrelin is produced in the fundus of the stomach, and that's why it's important to remove all the fundus. Also because it stretches, it's very thin, so for 2 reasons we have to remove it. But that decreases the amount of ghrelin after surgery. Also, by leaving the pylorus intact and the antral pump, so the stomach is going to empty faster. And I show you a study about this. And actually, there's the food is delivered faster into the small intestine, and that's going to produce similar effects that we see in the bypass, with the GLP rising and the other, hormones. We see similar mechanisms of the L cells, with the intestinal stimulation. We see similar changes that we see in the gastric bypass. This is the study from Italy that shows the gastric emptying before and after sleeve. Before sleeve in the dark blue, and they did it for patients taking liquids and taking solids. And then they measure the gastric emptying by scintigraphy. So as you see, the stomach empties twice as fast, after surgery with solids and liquids. So that's one thing. And also they measured the serum concentration of GLP also before and after sleeve gastrectomy, and they did it starting at 15 minutes, 30 minutes. And then for the solids, they went all the way up to 90 and 120 minutes. And that's a statistically significant difference of the GLP concentration after surgery at all different times with both liquids and solids. There's a lot of studies comparing now bypass versus sleeve. There's tons of them, but I'm going to just summarize them very quick in three slides. You know, the results depend on the years after surgery. So we have short-term results, mid-term, and long-term, and they are different. And you know, there's a little bit of difference on the outcomes. So this is a randomized controlled study from Poland. They randomized patients. 36 had sleeve gastrectomy, and 36 had Roux-en-Y. This is short term. So at one year after surgery, they lose almost the same amount of weight, 67% versus 64, very close, of the excess weight. The ghrelin, obviously, it only goes down after sleeve gastrectomy. Interestingly, actually, after bypass, we see a rise in the ghrelin after a year. So there are some mechanisms that we still don't understand. The levels of leptin, hemoglobin A1C, and the insulin-resistant values were equally decreased in both studies and in both operations. This is now mid-term and long-term, and this is a meta-analysis, so it's good to take a whole bunch of cases and compare the studies. This is a meta-analysis of the total number of patients is 5,000, and they followed those patients for between 3 and 7 years. And then they compared which one is better, sleeve or Roux-en-Y. In this study, there's a slight difference of better weight loss with the gastric bypass on the long term only. So only on the long term, they saw no significant difference between the two procedures for the comorbid conditions. This is another one, long-term results for another meta-analysis of 1,000 patients that had Roux-en-Y gastric bypass and 846 patients sleeve gastrectomy. Average follow-up was at least 5 years, and they went up almost to about 7-9 years. They found no significant difference in the terms of weight loss. Equal weight loss here. However, patient with the type 2 diabetes and the hyperlipidemias with the metabolic syndrome, they benefit more from the gastric bypass. It was not by too much, but they do benefit more. So the best evidence comes from you all heard about the Stampede trial from the Cleveland Clinic, Phil Shower. It was published in the New England Journal of Medicine. And Stampede stands for surgical treatment and medication potentially eradicate diabetes efficiency. So the idea of the study was to compare intensive medical therapy versus surgery. It was not intended to compare sleeve versus bypass, but we had some surprises because the way they randomized the patients, like 38 patients had intensive medical therapy alone, 46 patients had intensive medical therapy with sleeve gastrectomy, and 49 patients intensive medical therapy with gastric bypass. The primary endpoint was hemoglobin A1C levels less than 6%. So the initial results were very impressive. We know that surgery way superior than intensive medical therapy, 90% versus 5%. At 3 years, the first results were published at 3 years, there was no difference in terms of weight loss or diabetes resolution. So we kept doing sleeve to everybody. But then recently they came up with the 5 years results, and there is a slight difference for the diabetes resolution on the long term. But not by much, just by few percentages. So in summary, so the outcomes are summarized in short term, up to 3 years. There's no difference in the outcomes. However, for the long term, 7 years, we see weight-independent mechanisms. That's benefit more the gastric bypass. There's more changes in the intestine. All the incretins, the adaptation of the intestine. The bile acids, even the microorganisms. The microflora, microbiota. There's some changes that we think it has to do also with the weight loss. I did not find too much studies in the Middle East, but I did find one this is from Lebanon, a group of surgeons. They have been doing a lot of sleeves. They did 76 patients, laparoscopic sleeve from 2007 to 2010, and they have excellent weight loss results. 69% at 5 years, 70 at 6 years, and even 76 up to 7 years. And they saw, significant improvement or a resolution of diabetes, hypertension, and asthma with those very, good numbers that you see there. However, actually, in their study, 1 out of 5 patients had acid reflux after surgery. So this is one concern about the sleeve. You're going to hear about it. Well, there's few complications, but one of them, the incidence of acid reflux, we thought it was going to be very high after sleeve gastrectomy, but it's not actually. I will show you some data. The sleeve gastrectomy is still, again, safer than the bypass. There's a small chance of leaks of 5%, is as much as the bypass. However, when it happens with the sleeve, it's more difficult to treat than the bypass because the sleeve gastrectomy system is under higher pressure because there's the muscle of the stomach still intact and there's more pressure. So anything that leaks is going to be difficult to resolve and patient. They spend weeks in the hospital with on TPN, we put stents, we have to do more surgery on them or convert them to a bypass. But the good thing, it doesn't happen too often. Otherwise, I wouldn't be doing the surgery because they are very difficult to treat. Only in 0.5% of the cases. The stricture rate is very, very low. We see a higher incidence of superior mesenteric vein and portal vein thrombosis. We don't know exactly why, but some patients come with non-specific symptoms, and we do a CAT scan and we see clots in the superior mesenteric vein portal vein system. We put them on anticoagulation and they do well. We think it has to do with the change of blood flow, and also because they're going to be eating less, they get dehydrated, so it's very important to keep those patients well hydrated to prevent this. Usually they respond well to anticoagulation. If there's complete occlusion of those veins, the radiologists have to do thrombectomy and be more aggressive with the treatment. Now, the gastroesophageal reflux disease is still a little bit controversial, but we know as the patient loses weight, the reflux is going to improve. At least 65% of the patient will, as they lose weight, it's one of the comorbidities, right? So it's going to go away. But we found out that if a patient has a hiatal hernia and it was not fixed at the time of the surgery, those patients are going to have more trouble. So we always look for hiatal hernia carefully and fix it at the same time of the sleeve. And in my experience, we haven't seen any significant increase in the acid reflux. Still, a lot of studies are showing new onset acid reflux or even, persistent that, stay with them after surgery. So how we select the patients? Most of the time it's patient choice. The patients come to us and they are focused, they know which surgery they want. But we have to guide them, we have to advise them. If I see a patient with severe diabetes type 2, and usually if it's longer than 5 years and they are on 2 or more medications, there's some studies that show that this group of patients benefit more from a gastric bypass. Especially if they have metabolic syndrome, the male patient that have all the lipids and hypertension, they are very high risk, they could have a heart attack anytime. after they leave the office. So those patients have to be more aggressive with them and make them lose the weight fast, and they benefit more from the bypass. Patients with severe acid reflux disease, especially if they have Barrett's esophagus, actually that's one of the absolute contraindications for sleep. Because as you know, the Barrett's is a pre-malignant condition. Patient could have a carcinoma of the distal esophagus. So if they develop that in the future, you want to have the stomach intact, so they could do the surgery of the pull through and fix that esophagus. So you don't want to mess around, cutting the stomach away. Patient that eat sweets, a lot of patients come to me and they say, okay, I want to bypass because I know I'm going to behave better. With this kind of thinking, it's a big flag because we know they, even with bypass, they're not going to do this too well and they could regain the weight back. But it's a thought because they have malnutrition. I mean, we still do it because that's what they want. But we make sure they comply and they show behavior modification before surgery to make sure they are successful. The super obese patients, they lose initially less weight than with the bypass. But it's still safer surgery, and we give them the chance, to have a safer surgery and lose the weight, and some of them reach that weight. If they need a revision, then it's easier to do than with the bypass, and they have less problems to worry about. Now, patients that fail the band, there's a lot of them now. We've taken a lot of those bands out. So our thinking is, if we did a restrictive surgery, just the band, then how are we just going to do another restriction surgery, the sleeve? So there's a thought of doing, the combined restrictive malabsorptive procedure, which is the bypass. So they get more benefits. But that's still not clear. A lot of those patients do a sleeve and they do great. We still do the sleeve and they do very well. So one good thing about the sleeve, it has a lot of we don't burn bridges, like I said, and we could modify it. I think the next talk they're gonna speak about the mini bypass, but this is a sleeve that could be converted to the duodenal switch, and it could be done, in a safer way. The duodenal switch is like very risky. No one wants to think about it because it has a lot of complications. It's a major surgery. I don't do it. There's a few surgeons in Michigan that does it, but they have a lot of malabsorption and diarrhea because they leave only like 100 centimeters of common channel for absorption. But now, there's a single anastomosis duodenal switch, or you could call it almost like a mini bypass, where the common channel is 200 centimeters, and those patients have less diarrhea, less malnutrition, and they're doing very well. So there's few surgeons that are doing that now. The sleeve is also good for the elderly patients. The elderly patient at a higher risk. We don't want to create more problems to them with the bypass. They do very well with the sleeve. They go home the next day. Some of them they just stay one night in the hospital. Also, patients that are in the transplant list, either for liver or kidney. You don't want to do a malabsorption procedure because they're going to be on medications for the rejection and all that. So those patients, the sleeve is the way to go because everything stays intact and they could tolerate better the medications and they do well, after the sleeve and then they could qualify for the bypass. Do I have more time? So just a few quick slides. This is. Now you wonder, okay, what are we going to come up next? Well, we always try to do minimally invasive, less and less invasive. So this is a device. Some surgeons are doing the sleeve, but endoscopic, endoluminal, gastric plication. There's a surgeon in Cleveland actually doing it. He's good at it, but no one could reproduce his data, and it could be there's some problems with it because the stomach gets necrosis from the stitches and it could dilate. So, it's still like investigation on this one. It's a good device to narrow the gastrojejunostomy, and we have done several of those at my institute. the gastric balloon is like everything recycles. The history is repeated itself. That's the bad thing to do when everything keeps recycling. But now they have different shapes of the intragastric balloon. There's two of them. One is the dual shape and one is the single shape. And they are safer. But I think there's a use for the gastric balloon. Actually, it was approved by the FDA in the United States. And I think there's some patients that I cannot do it, not even sleep on them, especially patients that have a lot of abdominal surgeries and ventral abdominal wall hernias. You cannot get into that abdomen. A lot of hernias and scar tissue. So actually, I saw two patients recently, and I sent them to the guy that is doing a balloon because there's some good data that's showing that they could lose about 30% of the excess weight loss at 3 months. It could only stay for 6 months, so they have to take it out and then start all over again. But at least this is like a bridge to surgery, and for some patients that don't qualify for surgery. There's some complications. There's some cases of esophageal perforation reported, gastric obstruction, pancreatitis. The main thing, they cannot tolerate it. You have to give them so many medications for the nausea and vomiting. Having that balloon in the stomach is something, very, very uncomfortable. There's those new devices for the GI neuromodulation, and the one that was approved by the Food and Drug Administration, also in the United States, is the vagal blocking device, or the V-block. And here, the surgeons place those electrodes on the anterior and the posterior vagal nerves. The vagal nerve, controls everything in the stomach, the relaxation of the stomach, the secretion, and everything. So and that's an implantable stimulator that is placed under the skin. And it gives like a cyclic stimulation to that nerve. And believe it or not, that seems to work. There's a randomized control study. They did it on 162 patients. And some of those patients, they did the surgery, but it was a sham operation, so they did not implant the device. They found out at a year and a half, the patient that actually had the device, they lost 20% of the excess weight loss, and the sham group only 10%. So there's some results there, and there's other devices, but those are the main two that are approved. This is our experience at Hurley Hospital. Usually I do about 200 cases a year, and as you see, most of them are the sleeves. The sleeves is the main thing. That's everywhere. I think that's the trend. The band is slowly dying away, and the bypass. I think this is lower, but initially I was doing less bypasses, but when the data of Phil Shower from Cleveland Clinic came back, so now we are picking up more on the gastric bypass, doing some more patients. In conclusion, the laparoscopic sleeve gastrectomy have similar results compared to laparoscopic Roux-en-Y in the short term. Interestingly, post-operative changes in gut hormones are also very similar between the two procedures, with increased levels of GLP-1 and so forth. Gastric bypass, however, promotes higher diabetes remission, better lipid control on the long term only, but has higher incidence of complications. So any operation you choose, I think is going to be fine, but make sure you mention it to your patients. The patient, they have better control, especially if they have morbid obesity. The surgery has to be part of your plan in the future if they're not able to lose weight and control the diabetes usually after 6 months or 12 months. I take any questions, or you want to wait? Thank you very much.